Well, a bit of an update on the coronavirus epidemic, and again, trying to keep this evidence-based. So today, coronavirus contagion and complications data. More people are now infected with coronavirus than were infected in the SARS epidemic of 2003, the severe acute respiratory distress syndrome viral epidemic of 2003. In the 2003, 8,098 reported cases of SARS and 774 deaths. So quite a high death rate from SARS. The case fatality rate was fairly high. But there's been no reported cases of SARS that I've been able to find since 2004. So the SARS epidemic, in a sense, was a great success. It was contained. And we've had no new cases, which is pretty wonderful. But as of today, with coronavirus, we're up to that many deaths, 14,627. That's the official figure. 305 deaths and 346 people are documented to have recovered. Now, just before I say something else, I'll just say that this data is from the Johns Hopkins website, and Johns Hopkins are doing a magnificent job of mapping this epidemic. I'll put the link to their website there, and you can download the live information and look at it any time you want. But what I wanted to mention here was the case fatality rate, the CFR, the case fatality rate. And the thing is with this, there's a lag problem. So this SARS data was compiled when everything was done and dusted and after the epidemic, so we could work out the case fatality rate. And we see there it's just a little below 10%. But the problem with coronavirus is we're still in it. So 305 deaths, but 346 officially recovered. So there, if we take the deaths to recovery, it makes the death rate look catastrophically high. God willing, it's not. But if we look at the total number of cases and the number of deaths so far, we're going to get a much smaller, around about 2% case fatality rate. But the problem is we don't know yet. It's too early to tell because of this lag effect. So as we mentioned in our graph, many times you recognise this if you've watched these videos. This red line is the person being sicker, most sick, getting better. The purple line is the antibodies, the body's immune response. The green line is the viral numbers. And yesterday we noted that the viral numbers do tend to stay up for a period of time when the patient's feeling better, which was concerning from yesterday's video. But we also noticed there could be sequelae after the person had recovered, sequelae, complications arising from the initial condition. And this is what we're not quite sure about at the moment. So quite what the case fatality rate is going to turn out, someone will be able to calculate this in a couple of years' time when the epidemic's all over. But at the moment, we really don't know because of this lag problem. And for this reason, there's a very interesting paper published in the Lancet. Now, the Lancet is perhaps the most reputable medical journal in the UK. And this study was published on the 31st of January, and it's nowcasting and forecasting. So nowcasting is using the data we have to try and work out the overall data, the overall now, the current position, and to forecast the future. Now, the basic reproductive number in this study, the R0, they worked out at 2.68. And the 95% sure from the data they have, even though it is a nowcast and a forecast, the 95% sure that figure is between 2.47 and 2.86. Now, I've had so many emails talking about other studies where the R0 is much higher than this. Now, I've looked at these studies and they are based on accepted mathematical epidemiological modelling, but at this stage I'd have to say the data is just too uncertain to be sure. But unfortunately this is kind of nearer 3 than it is nearer 2. So what happens is as we mentioned this before, you have an index case here. Now, if the R naught is 2, that can give rise to 2 new cases. Each case can give rise to 2 new cases, and each of those can give rise to 2 new cases. Which of course is bad, because if the R naught is greater than 1, then the disease is going to spread. So if R naught is 1, that would mean that one person infects one other person. And that would mean that the number of infected people would stay the same. If the R naught is less than 1, then each person would infect on average less than one other person. Therefore the numbers would decline. But if the R naught is anywhere above 1, then we have this potential for spread. But of course, if the R naught is 3, then what we have then is each person can infect 3 new people. Like that. Then each of those can affect 3. And I think you can see there that the numbers are going to increase very much more rapidly. This is the average figure, of course. It's just the average figure. It's an estimate, really, of spreadability of the contagion. So what this study is now saying, based on mathematical modelling, it is an extrapolation, but they're saying 2.68. And they now cast, from the information they have, is that actually the number of people infected in Wuhan, we know the official figure, the number of documented cases was 14,500. Well, they think the actual number of people that could be infected from their mathematical modelling is actually nearly 76,000. And again, from their models, they're 95% confident that that number is between 37,000 and 130,000. But what for sure has happened, and these are the numbers they estimate, is there's been city seeding to other cities in China. And seeding's just what it says. 1 or 2 people will get to a new city and they'll start spreading it. And as we looked at yesterday, carriers can be asymptomatic. So cities are seeded, and then the numbers grow in those cities. It's so we go from Wuhan, and then various other cities can be infected from that. Clusters will grow in these cities. Then, of course, they can spread to other places. And one of the things that concerns me is there's so many links now between China and many African countries, for example. There's an awful lot of excellent Chinese infrastructure projects in African countries, but that means people are going back and forward. So from these, there's potential to go to other cities. So this could be City 1, City 2, City 3. And as we've mentioned before, I'm fairly happy that the 2 cases, it was a Chinese student and his mother from York, we now know was affected in the UK. I'm happy that they're contained, but we have a good health system in this country, or at least a good containment system. In countries where the health system is less evolved, then these cases could increase quite dramatically, and you'll get self-sustaining cohorts of infected people in Chinese cities and in other cities around the world potentially. So that's what this study is talking about. And the epidemiological doubling in this Lancet study was 6.4 days. So they conclude that the epidemic is growing exponentially in multiple major Chinese cities. And as we've just talked about, I'm concerned about international seeding, that there'll be self-sustaining cohorts of people with the virus in different cities, especially those with poorer access to healthcare, where the numbers could build up dramatically and quite quickly. Well, we know the numbers could potentially double every 6.4 days. Now, the other cities in China, that they may well follow, because they now have self-sustaining infections in these cities. So the data could be similar to Wuhan in 1 to 2 weeks' time. And just to mention that this data here, this estimate was for the 25th of January, up to the 25th of January. And the same team estimate that the peak of the epidemic in Wuhan will be the 20th of April 2020, with other Chinese cities being behind that. Now, what happened is, as more and more people are exposed to the virus, more and more people will develop immunity. And this herd immunity effect will curtail the spread of the virus. But that's estimated not to be happening until April, which of course is quite a while off. Now, if transmissibility is reduced by good community health measures and isolation, then the peak would occur later, but the numbers would be smaller. And we've mentioned overseas cities' potential for self-sustaining outbreaks, new epicentres in overseas cities. And the Lancet paper says unless substantial public health interventions are implemented immediately, there can be substantial export of pre-symptomatic infected people in the incubation period. This is what we looked at yesterday. We're now fairly confident, at least there's one or two cases, still early days, that people are infectious in the incubation period. Different to SARS, the same as influenza. Now, how infectious people are in the incubation period, we're not sure. But there's certainly cases of it. So people can be flying around, feeling fine, incubating the virus and still spreading it. And we did notice with concern that people who might not even know they've had the virus can still be infectious, at least sometime after they've had the virus, because the viral load does seem to stay up, at least for a period of time. Now, the paper does mention the possibility of super spreaders. These would be people in particular circumstances who may be moved into a very crowded environment. Hopefully that's not going to happen very often. Now, the World Health Organization is currently saying that we don't need to restrict flights to China. Now, many countries, I think New Zealand, the UK certainly, others, have taken it upon themselves to stop flights from China. And it's not for me to tell the World Health Organization what to do. But my personal view is they're being a little liberal here. I would want to reduce the possibility of seeding of foreign cities. And the Lancet paper does say that substantial, even draconian measures that limit population mobility may be necessary for a period of time, and I agree with them. And this could involve cancellation of mass gatherings, schools closures, working from home, if the virus is in an area, that would be the case. I'm not saying we should do that all around the world now, of course not, but this needs to be taken seriously. And what we're uncertain about is seasonal uncertainty. Now, the data from the SARS virus shows it doesn't like the heat. So it's more likely to be spreading in winter. And of course, in winter, it's in China, it's winter now, but as it is in the UK, of course. That doesn't mean it won't go to hotter countries like Australia, but we're still uncertain about that. But it looks like the virus probably won't like warm surfaces. So that might reduce surface spread. Now, the second paper I want to talk about today was in the Lancet. And this was a study of 29th of January. Again, the Lancet. Study of 99 patients with 2019 novel coronavirus. And they all had pneumonia diagnosed by PCR. This is the genetic test for the presence of the single-stranded RNA virus, polymerase chain reaction. What it does, it takes just one strand of the virus. So you get a strand of the RNA virus that's in the coronavirus, and it multiplies it up into numerous copies. So it's becomes much easier to recognise. Now, this test is a bit difficult. There are more kits being made available, but the virus has been isolated in Australia, And the Australians have made live, at least I think they're live viral preparations available to labs around the world. They may be attenuated viruses, I'm not sure. But they've made the actual virus available to labs around the world. And that means the labs around the world are now able to develop an antibody test. So at the moment, we're testing for the number of viruses. We're testing for the presence of the virus, the green line. But if we have a test for the antibodies, that would be good, because that means we can test for the purple line as well, the antibody line. And we can test for the antibodies. HIV, for example, we test antibodies. We don't test for the antigen. But that's not quite here yet. Now, this is a retrospective single-centre study of poorly patients. Now, I'm not sure how official this term is, but in intensive care we always called patients that were ill poorly. Poorly means that they're really quite ill people. So this was a hospital in Wuhan, and these were patients referred from other hospitals. So these are patients that already had pneumonia. So these are patients with pneumonia. So patients were admitted to hospitals in Wuhan. If the patients had pneumonia and they're very poorly, they referred them on to this hospital. And of those patients, the average age was 55. More men than women. 51% had previous chronic diseases, which means, of course, 49% hadn't. But what I really wanted to flag up here was the clinical features of patients with pneumonia. So 83% had fever, 82% had cough, shortness of breath 31%, muscle aches 11%, confusion. Now infection and sepsis studies, we call this AMS, altered mental status. And the people that were confused are usually more likely to be those that have residual capacity in their brain anyway. People that have already got some pre-existing medical conditions usually are more prone to that. Headache 8%, sore throat 5%. Now this was interesting. The upper respiratory tract symptoms, rhinorrhea and sore throat, less common. So we know that some coronaviruses cause the common cold because it infects the upper airways. But it seems that this virus has a preference for the lower airways rather than causing a cold type feature. So that's reassuring. If you get a cold, it's a lower probability that it's the coronavirus. Some got diarrhea because this virus can be excreted via the gastrointestinal tract and affect the gastrointestinal tract. And of course, there's obvious hygiene implications from there, washing hands when moving to the toilet and avoiding fecal contamination of surfaces. Now, 75% of these patients had bilateral pneumonia. It was in both lungs. Multiple mottled and ground glass opacity. That means that there was areas of consolidation in the lung like we looked at yesterday. 1% had pneumothorax. That's a rupture of the pleural membranes letting air into the pleural space. 17 developed acute respiratory distress syndrome and 11% died. But I stress again, that is the patients that already had developed pneumonia. So these were complications of patients that already had complications and they had this pneumonia. So here we have the alveoli and the air sacs. And in pneumonia, these can fill up. And in acute respiratory distress syndrome, these can fill up. And when they fill up with inflammatory fluid, they're more dense. So when you look at the chest x-rays, that's one long field, that's another long field. When you look at x-rays, normally there's a lot of white in them because the x-rays go straight through. But these patients had multiple opaque areas because they had these consolidated alveoli in different parts of the lungs. This is why it's so dangerous and problematic, of course. Okay, so that's just a quick update on aspects of contagion and clinical features of patients with complications. Again, I'll post the links for these papers before. Read them yourselves. I might have got something wrong. I might have misunderstood. But let's go forward from an evidence-based perspective. I think before I finish, I don't know. Yeah, I'll say one thing. I've recently worked on intensive care and A&E environments, and if a lot of people do suffer from these complications, If there's large numbers, we're not going to be able to treat them all. Let's hope there's not.